Paul.
Okay, and I'll share.
Okay, so hi everyone, welcome to Nutrition Grand Rounds. So today we have Dr. Paul Wischmeyer. I don't think he probably needs much of an introduction to everyone joining, but he's one of our anesthesiology ICU attending physicians. He's also one of the physician directors for our TPN nutrition support group. He's published numerous articles on clinical nutrition. And he really has an expertise that we appreciate. And I'm really looking forward to this one. He'll be talking about anabolic agents and how these can affect our patients and the nutrition care for our patients. So with that, I will pass on to you, Paul.
Thank you. It's great to be with all of you here today and talk about a subject actually that I'm very passionate about, and one that I've wanted to create a lecture for a long time because I think there's a lot of new data that's worth sharing. And so we'll cover a range of agents with a focus of a large part of the lecture on testosterone and those agents, but some other catabolic and anti-catabolic agents too that I think are worth knowing about and helping patients recover. These are what I'd like to call not my conflicts of interest, but my alignments of interest. I'd like to think that I'm not in conflict with the NIH and the Department of Defense and the industry partners that we do research with, but that we're in alignment in trying to help improve outcomes for our patients and help them live longer, healthier, better lives. So these are the folks that fund the work we do. And I think the key message that I often lead almost all my lectures with is that it's critical that we not just take responsibility for the things that happen in the hospitals we're rounding every day, but that every day on rounds, we're really focused on what happens after the patients leave us. And what are we going to do each day on rounds, not only to get them through the next day of their healthcare needs, but the rest of their lives as they recover from whatever it is that's led them to be admitted to the hospital. Because ultimately what we want to do is create survivors of our patients, right? Survivors that go home and live the lives they want to lead, not victims, patients that perhaps never meaningfully go home or that end up in SNFs or rehabs or nursing facilities and never return home to the meaningful life that they came to us to restore, because that's ultimately what our patients want. Because ultimately, I think the biggest thing our patients want from us when they go home is to be able to walk down the street with the people they love again, to be able to hold their grandchildren and their children and live the lives that they led before whatever illness has brought them to us. And so as we think about what's important to our patients and what they value most, I want us to think about what patients really put the most emphasis on. And so I have a question for you. If your patient leaves the hospital alive, is that alone enough to make your care successful? Because who wants to live, sorry, this is in Portuguese, but this says, who wants to live to 70 like this? And if you were in the room with me, I'd ask you to raise your hands. Or perhaps live to 100, but look like this. And so again, that's the real question: quality of life versus quantity of life. And ultimately, I want to ask you about, tell you about a survey they did in people who care more about quality of life than probably anyone that will ever care for or meet. And these are athletes. And they asked elite Olympic athletes who were so weightlifting athletes, power athletes, elite strength athletes in the Olympics, before the Olympics, a simple question, and it gets to quality of life. And their question they asked was, you're offered a banned substance, a steroid perhaps, an illegal substance, with two guarantees. First, you will not get caught. And second, you will definitely win your event. And if I was in the room with you, I would say, how many do you think said yes? And as it turns out, only 3 said no. So again, and those 3 probably shouldn't have been there in the first place. So clearly, athletes would value winning their event over anything else. So now, same poll, new scenario. Now the athlete's going to win every competition for the next 5 years. Okay. Then they're going to die from whatever substance that allows them to win every competition. How many of them still took the drug? Well, the answer is more than half. This is what quality of life means to an 18 to 21-year-old. That's how old these athletes were when they took the survey. Half of them would still take the drug if they could lead what they would consider the utmost of quality of life for the next 5 years. What do you think this might tell us about a 70-year-old or an 80-year-old or a 90-year-old patient and what they value? I think all of us would say, and our patients, when they're surveyed, say the same, that we value quality of life over quantity of life. And so I think as we think about how to optimize our patients and the things we should always be thinking about each day on rounds, it's essential to remember that before our patients come to us and as they prepare to leave us and after they leave us, we need to be training patients to run and win the marathon of their lives. Because for many people, the cancer, the major surgery, the trauma, the critical illness that they're facing is truly the marathon of their lives, right? And you can't run a marathon. And if I was in the room, I'd ask how many to run a marathon. Maybe some of you have, but any race realistically of any length, you can't optimally do, or even sometimes do at all, if you don't train. And training involves exercise and supporting your muscle and good nutrition and all the things that go into this kind of race. And this truly is the race of their lives. And so what happens to our patients when we ask them to run the marathon of their lives without the right nutrition and training, right? Not the marathon of the road, of course, but the marathon of the hospital. And so to tell you about that, I want to tell you about a patient that actually we cared for here at Duke. It was a patient, and we have permission to tell his story. In fact, the family asked us to tell his story. He was a patient of Julie Thacker's and of mine a few years ago. And his name is Elijah. And he was an 89-year-old who came to us for a partial colectomy. And he had some COPD, but otherwise was a very fit and healthy man. Now, he had colon cancer, and so he'd been losing weight for about 3 months because he'd not been able to eat very well, and the cancer had been really limiting his ability to nourish himself properly. So he'd had a pretty significant weight loss. And he said when he came in, he feels weaker than he used to, but he's still very active. In fact, he told me that just the day before surgery, he was up on the roof of his church, fixing the church roof. So this is a very active, really quite fit, despite his cancer and his age, 89-year-old gentleman. And so is this gentleman ready for surgery? And this matters a lot to him because the other thing he told us was he was so excited to get this surgery done with because he couldn't wait to travel to see his new granddaughter after the operation. He had a new granddaughter he'd never met. And so this was really important to him to get through this and be able to live his life in such a way that, of course, he could travel to see his granddaughter. So he goes to the operating room and he does pretty well for the next few days. But then ultimately, he develops acute abdominal pain and rectal bleeding. And unfortunately, he ends up needing to be rushed back to the OR in shock. And he goes to CT scanner before he goes to the OR, and they find an anastomotic leak. And in the OR, unfortunately, they find ischemic bowel when his belly's back open, and he goes into shock. And ultimately, he has a cardiac arrest on the table, and he gets a whole 2 minutes of CPR where his heart is fully arrested in the operating room. Remember, he's 89 years old. He's now undergone major surgery. He's malnourished. He's got ischemic bowel. He's had a cardiac arrest. Comes back to the ICU where I was caring for him with an open abdomen. He's very weak. He's malnourished already. And so I can tell you that there were more than a few nurses and residents and other caregivers on the team that began to ask questions about what we were doing here. And they began to ask, can this 89-year-old who's had a cardiac arrest survive this? Is he too old and weak and too sick to recover? And maybe the right thing is just withdraw care, because how is he going to survive this after going through all this? Well, of course, Dr. Thacker and I, our surgeon and I, knew what his family thought and what he had said he thought. And the answer, of course, was no, this is not what he and the family wanted. And so, of course, even though he's in this tough spot, we were able to extubate him on day 3 after they closed his abdomen. And he, again, committed to the fact that he wanted to keep fighting. He wanted to not just survive this, but live the life he wanted after it. Remember, this is a very active man who led a very active life before. So he just doesn't want to survive this and go to some nursing home. He wants to survive this and meet his granddaughter and go back to fixing the roof of his church. And so we committed, we said our team was going to fight for him. And so the question is, A, can we save him? But B, can we not only save him, but get him back the same quality of life that he had when he came to us, right? And I think we all wondered if we could or not. I mean, this is an old patient who's gone through a lot, an elderly patient. So if we're going to do that, we have to be better than we've been in the past and better than we've been previously. How are we going to do that? Well, of course, it's going to take a combination of therapeutic nutrition, good rehabilitation and physical therapy, and of course, perhaps some of the more specific training that we are now doing that many of you participate in some of our RIM-HIT studies and other CPET guided exercise studies. And perhaps it's going to take a little more. Maybe it's even going to take some of the same drugs that athletes take to recover when they're facing massive challenges and stress. So what are our goals to recover and prepare patients like Elijah to get their lives back after such massive insults? Well, of course, one massive key is to recover muscle mass, right? And of course, athletes that look like this at 260 pounds and 4% body fat don't get there with this nutrition and exercise, right? These people do a little more. We'll talk about that. But of course, the basics we have to face are we have to have the right nutrition, the right exercise. We have to personalize it. It has to be dosed. We have to use metabolic cart. We have to be measuring their exercise abilities. This has to be personalized and it has to be measured. So Elijah was in the ICU and we actually were able to measure, of course, his muscle and body composition. And so we were able to learn a lot. It's the BIA analysis. So you can see that he had very little muscle mass and quite a bit of body fat. This was his muscle sound analysis. So you can see his muscle was quite small and his mass was quite low. And there's a lot of subcutaneous fat, despite the fact that he's malnourished and actually quite thin appearing. There was still a fair bit of fat that made up his tissues and very little muscle in his leg. And so again, what are the things we need to focus on? And we'll spend a little time, not much, just reminding people that, of course, you can't build a house without bricks and you're not going to recover muscle without protein. And that's essential. And so that has to start with there. If you're going to use anabolic agents, like we'll talk about, if you don't deliver the adequate protein patients need, it isn't going to help, right? And so I think that's where, when we're talking about 89-year-old patients or any aging patient, we have to understand anabolic resistance. And anabolic resistance is the concept that as patients age, it takes more grams of protein to make the same amount of muscle as when we were young. And that changes every year we get older. So all of us are going to need to take in more protein to maintain our muscle mass than we needed to take in when we were 21 or 18. And so, of course, not all elderly folks or older folks have to lose muscle mass. And this guy does pretty well. But Frank Zane doesn't look like this just because he eats well or because he exercises, right? He does more than that. But I think we can learn a lot from athletes, right? I think the idea of giving boluses of protein, I think the ideas of bolus tube feeding and some of the understanding of the science around having your amino acid levels go from low to high is really critical. I think encouraging patients as they begin to take oral nutrition to take in protein at night, branch chains, leucine, all these things can be beneficial. And of course, rehab and exercise is critical. But then the anabolic resistance of critical illness, like Elijah's suffering, is even more dramatic. And so we all are of the belief and have witnessed ourselves that it's going to take other agents, like we'll talk about today, HMB, creatine, testosterone, propranolol, and anti-catabolic, to actually optimally recover patients like Elijah and really all of our patients optimally. Because again, our goal is to create survivors of our patients and not victims. And if we're going to do this for Elijah, what else can we do to save him and return him to the life he came to us to give back to him, to meet his granddaughter and go back to fixing his church? So, of course, is enough or the right nutrition enough to win the war? Even if we are perfect in our nutrition delivery, is this going to get him back? And there's a lot of data. This is some of Gordon Jensen's original data, where yes, if you're acutely ill and you're not fed well, you're going to lose a lot of muscle mass very quickly, very quickly. But even in ideally nourished patients who receive perfect nutrition delivery, there's still significant and continued loss of muscle mass if we don't do more. Calorie delivery alone won't stop this. It's because we as humans are not evolved to survive critical illness, cancer, major operations, major traumas. Mother Nature never intended us when we got mauled by the tiger or hit by the bus to survive. And so the mechanisms our body have evolved don't work in these settings. We are not evolved to survive this optimally. And so our body becomes hypermetabolic and catabolic. And we can feed and feed and feed patients. And I know all the dietitians have seen this. And if you've ever worked in a burn unit or worked in the CTICU, you see this. You can feed patients 40 kcals per kilo, and they will still lose weight and they will gain no muscle. We know a burn child, in fact, will remain catabolic for 2 years after the burn injury. And in fact, if you don't use some of the interventions I'm going to talk about, you can feed them perfectly, and all they'll do is put fat in their liver, and they won't gain any muscle. We have to do more. And so can we learn from elite athletes to do more than just eat right to help our patients recover? Because again, to look like this guy, you can't just eat a lot of calories or a lot of protein or just lift weights. And of course, this involves taking the right catabolic, right anabolic, and right anticatabolic agents. And of course, the long debate has been, there's a lot of stigma around these agents, and people have said it's not fair and all these other things in athletes. But what about in our patients, right? And there's still lots of athletes who think this should be fair, right? If steroids are legal for athletes, and they should say Photoshop should be illegal for models. And so lots of athletes, of course, have depended on these drugs, still depend on these drugs, and they work. The evidence is all around us. What modern elite athletes have been able to achieve is not normal. Just like surviving critical illness is not normal. They're superhuman. And if you give our patients their lives back, like Elijah, is a little superhuman as well, right? How do elite athletes do it, right? They use performance-enhancing agents, and the data for the incredible success of these agents are all around us, right? Nobody can look like this without the drug stacks that these athletes take, and they're experts at it. They have physicians monitoring them. They monitor every level of every hormone, every function in their bodies when they do this correctly. We know, of course, that Lance Armstrong achieved things, and the bikers who were taking growth hormone and other agents in that era achieved performances and output that have never been matched since those drugs have been made illegal in biking. So in professional cycling, those athletes could do things that now they cannot do because they don't have access to those substances anymore because they're tested. And world records, even in the Olympics, do they mean anything anymore? Just looking at the Beijing Olympics alone, 43 world records and 132 Olympic records were broken in one Olympics, and those numbers continue to explode. And of course, training and nutrition have improved, but not that much, right? And I think the best example for any of you who follow baseball is there was a home run record that stood for many, many years, and no one ever thought would be broken until Barry Bonds and Sammy Sosa and a few other athletes broke it multiple times until they started testing for steroids. And then virtually no one person has broken it since. And so how is this possible, right? This only became possible a few years ago, and a lot of this change has happened over a very short period of time. We have not evolved as a human species in that period of time. This is what performance-enhancing drugs and substances do for us. And so again, evolving to survive major surgery, cancer, what Elijah went through, and critical illness is superhuman. And so again, it takes other interventions besides just nutrition and exercise to optimally recover our patients. And I think this is a paper that Amy Pastava and I published some years back that looked at the role of anabolic agents in critical illness. And I think the reality, right, of course, the things that lead to the weakness and disability of our patients, and often ultimately their death, are a combination of bed rest. Beds are poison. Patients should not be in them during the day. They should only be in them to sleep. I tell patients that all the time. Reduced anabolic hormone secretion. When we measure testosterone in our patients after 2 or 3 days in the ICUs, I will show you they're zero. And then malnutrition. And this leads to significant physical dysfunction and death. And so it's going to take all 3 areas of therapy to help patients recover and improve. And so it's not just rehab, it's not just nutrition. We have to have the body be able to use the rehab and the nutrition actually effectively, because the injuries and illness prevent that in most cases optimally. And so can we pump our patients and help them to recover? And we'll talk about a few agents that are some of the best researched, the most accessible, and the safest of all the agents we can give our patients. And the first is HMB. And HMB, of course, was developed and it is intended to intervene on this vicious cycle of catabolism, right? As patients are aging and they're ill, they have an increased amount of inflammation that causes muscle breakdown and impairs muscle synthesis. And again, you can feed and feed and feed, and they will continue to break down muscle. They will not be able to use the nutrients. And so HMB was intended to increase mTOR activity, which is vital to muscle mass, and to reduce inflammation. It was actually developed for wrestlers at Iowa State many years ago to gain body mass or muscle mass without gaining fat mass or other weight. And so again, it's to break this vicious cycle that we've all witnessed in our patients. And so again, this is the critical link that, at least that's what this nutrient is intended to do, to allow nutrition to be turned into muscle to allow patients to recover. For those of you who've never seen or learned much about HMB, it's an active metabolite of a branched chain amino acid leucine. It's naturally occurring in our human muscle cells. It's found in very small quantities in food, but you'd have to eat a lot of them, so I'm going to show you to get enough. And it's been tested and studied in numerous studies up to 6 grams per day, although the most effective dose is 3, as we'll talk about. You really couldn't eat enough to get enough HMB. It would take 3,000 avocados or a lot of meat or a lot of milk or a lot of catfish to get there. So again, it works by reducing muscle loss and inducing muscle synthesis. So it impairs enough kappa B signaling, and it increases the mTOR signaling that allows muscle to be gained. There's numerous trials. There's way more than 100 studies now. It reduces inflammatory response. It improves muscle lean body mass. The original data in HIV and cancer patients, that's where it was studied first. Lots of data in the athletes to improve muscle gain and performance. It's very safe. And there's a lot of good data in a range of patients to show the benefit of this intervention. So this is one study that was looking at healthy elderly women. These weren't sick patients. These were just elderly people. And it looked at HMB versus a placebo, both receiving exercise. And so what they found was there was significant improvement in muscle density in the patients that received HMB, as is monitored by CT. And most importantly, there was a significant 60% improvement in their 6-minute walk test distances. And so this is the change in their 6-minute walk test. So these patients, they weren't patients actually, they were healthy people. So everyday people are able to walk further, even in the elderly population, when they take HMB. And so what about sick patients? So again, in hip fracture patients, this was studied. You can imagine this is a population that has most of its morbidity and mortality happen because of the muscle dysfunction and disability they suffer after the hip fracture. And what they found was it not only helped heal their wounds faster, and they had better wound healing, which is one thing that HMB is known to do. It's in Juven. Of course, I disclosed I have done research with Abbott. And so they make this formula of glutamine, arginine, and HMB, and that's been targeted for wound healing and studied for that. But it also improved the number of patients by 3-fold that were mobile at the end of the study. So again, it improves mobility in patients and really helps them recover. And then there's enough trials now. There's many, many trials in the elderly folks that there's now big meta-analyses even, and you can see the data for muscle mass improvement is quite significant. And again, they're not just gaining weight, they're gaining muscle mass specifically because their fat mass doesn't change in these studies. And these are done by some of the very best researchers in nutrition. Nick Deutz is the editor-in-chief of clinical nutrition, and there's many other trials by good authors as well. And so I think there's also been meta-analyses in sicker patients. This was Danny Baer's meta-analysis. She's a PhD dietitian, critical care dietitian in London. Actually, she works in the same hospital as John Whittle, for those of you who worked with John. And she's a very good friend and an outstanding dietitian researcher, a real example of the amazing things dietitians do every day, not just clinically, but research. And she did this really wonderful meta-analysis and showed significant benefits of HMB and then the HMB combinations and the HMB ONS products on strength. And so again, in terms of recovering muscle mass, there was clear benefits in a range of sick patients as well, but we need more trials, of course, and more trials looking specifically at 6-minute walk test and strength and things of that nature. But again, looking more into the hip fracture population, this is a larger trial of hip fracture patients using HMB with vitamin D. Vitamin D is vital to muscle mass. It has to be normal to gain muscle properly. And what was great about this study was they showed that the patients who had hip fractures who didn't get HMB had significant losses in muscle mass, really dramatic, right? They lost a lot of muscle quickly, and the HMB population didn't lose muscle. And that's the recurring theme of this nutrient. When you're sick, and if you take HMB, you don't lose muscle mass. And I think that's the remarkable thing. In fact, I'm going to show you a more impressive study for its effects on bed rest in a minute. So again, this really, really helped in this population. And so I think the other critical thing to know is that muscle loss in people is not just the illness, but the bed is evil. If I took one of you, say at age 21, or if I took a young, healthy 18 or 21-year-old and I laid them in a bed for 28 days, they wouldn't be able to walk at the end of that. NASA did those experiments with astronauts to study the lack of gravity and how critical it is to maintain muscle when you sort of are not under the impact of gravity or you're laying in a bed. But if you're sick and you're elderly, or actually before you're even sick, if you're just elderly and you don't get out of bed for 10 days, you lose 5 times more muscle. So again, the dramatic effect of bed rest in the elderly cannot be ignored. It's dramatic. If you're a sick elderly person, say like Elijah, that happens in 3 days. Massive loss of leg lean mass very rapidly. So this is what our patients are facing. Now, HMB has been studied and looked at for its effects on this. And this was a study done by Nick Deutz, who's an outstanding physiologist. Actually, Krista and I are doing research with him on her R01 that she's submitting. He does muscle tracer and muscle physiology at the highest level. And so he studied bed-rested elderly patients, and he found if you don't take HMB, if you take a control, you lose significant amounts of lean body mass, 2 kilos, in fact, which is a lot for an elderly person. If you did take HMB, you lost virtually none. So this is the most potent agent I've ever seen for the prevention of the lean body mass loss in the elderly. And I think this is the most important study, I think, of the group. This is one of the most physiologically sound and best studies that have been done. So I think this is really compelling. 92% reduction of muscle loss versus control. This is why we encourage HMB so aggressively. What about in sick patients on ventilators in the ICU? Like Elijah was. So this was a randomized trial of HMB and COPD patients on the ventilator. And again, a significant, about double the number of patients had improved pulmonary function and got off the ventilator versus those who didn't get HMB. Many years ago, when I used to do pediatric ICU, we used to get patients from overseas, the Middle East and other parts of the world who were stuck on ventilators as kids. And way back when EAS was the only maker of HMB and creatine, we would get creatine, HMB, and glutamine. And we got many of these patients, virtually all of them, off the ventilator by improving their muscle strength and their lung function that way. And so again, it also reduces CRP because it has an anti-inflammatory effect. So there's a lot of data for HMB in a lot of different areas. In the surgical world, you know, a lot of us take care of surgical patients, I as well. There's great data in patients with hip fracture that it improves muscle mass versus control. In knee surgery patients, the quad muscle strength and total knee replacements patients was quite a bit better. So that was significantly improved. In heart surgery patients, so in cardiac surgery patients, it reduced length of stay by a day and enhanced recovery in that group. And then in pelvic and extremity fracture patients, there was a significant improvement in fat-free mass and recovery in those patients. And so I will tell you for Krista Haynes, one of my partners and mentees in our research we all work with, she's going to be using HMB as part of her elderly trauma study for elderly trauma patients. But I think, and sorry, this is in Portuguese again, but patients, this is the most important HMB study. This is the most important ONS study ever done. And this was a study that in 78 centers and 650 patients that looked at giving an HMB enriched oral nutrition supplement for 90 days after hospitalization. And what this showed was that patients who got HMB versus the placebo had a doubling of survival or halving of mortality versus patients who didn't get it. And this data is remarkable. Every 20 people who got an HMB containing nutrition supplement had a life saved. You save a life when you do this every day. And it was true at 30, 60, and 90 days. This is more cost effective than the influenza vaccine or aspirin for stroke. That's how potent this is in the cost versus benefit analysis data that's been done. And of course, it improves strength as well. And so they looked at hand grip strength in many of these patients, and that was markedly improved as well. So I think this is really compelling data that this improves outcome and reduces costs. It's one of the most effective interventions we have to reduce the muscle loss from not only illness, but from bed rest, which is really something that I think we need to focus reducing in our patients in because they all suffer it. What about creatine? So we don't use creatine very much in the hospital. We've used it in some of the heart transplant patients here at Duke to help them prepare when they're too frail to be listed. I often ask the pharmacy to get it with not much success unless I'm on the cardiac units. But the creatine has more data for its benefits on muscle and strength than any other supplement that's available on the market, any other intervention. So again, it's also the most popular supplement in the market. Even in 2001, more than half of 17-year-olds had used it when they surveyed high school athletes. So again, this was an incredibly widely used supplement. My son, who's in college now, takes it. All his friends take it. The data is probably 75% or more of athletes now take it. So this is something many people are taking. And for good reason. There's really good basic science to show that what creatine does is it works in the muscle and in the brain cell and many other cells as well to resynthesize ATP. So if you can lift 100 pounds 10 times, if you take creatine for a week, you'll be able to lift 100 pounds 15 times. And that leads to increased muscle mass because you're able to do increased resistance training. And so it's for short duration, repetitive maximum bouts of exercise, like standing and walking and sit to stands and the things our patients do to get out of bed, all critical. And so this is really critical. And so that's how this works, like getting out of bed. And that is one of the most important things our patients can do. So there's a lot of great data, and I'll tell you there's some great infographics on social media. These came from Instagram, from Physiognomics. If you don't follow them, you should. And this basically showed that, you know, the average strength increase in reps to failure when you take this for a short period of time is about 5 to 15%. There's the Pubmed IDs there if you want to look that up. But the data is very compelling, and there's thousands of studies. And so the International Society of Sports Nutrition has even said this is the most effective supplement there is for athletes, really for anyone, to increase high-intensity exercise capacity and lean body mass during training. This is true for men. This is true for women. This is something you should take if you're not taking it yourselves, much less your patients. There's really great data for increase in muscle mass. This goes way back. There's many, many studies that show this, but you can see significant increases in fat-free mass from using creatine as part of a rehab or training program. The question was, is it safe, even in high doses? So it's been studied over multiple years in subjects, college athletes, or other subjects. So in 5 years of data, when they follow kidney function, all the other things, there is no risk to the kidneys. There's no risk that's really seen with it. It's a naturally occurring part of what your body does, and you're just supplementing it. So there's no effect on renal injury. There's no effect on any of these things in many, many years of study. And so again, the dose that's been found to be effective, despite what the label says, the label will tell you to take more. You don't need to. 5 grams a day works for most people. I will tell you, I load with 10 for 7 days because it saturates the muscle faster. The effect is faster. And then you take it for 5. The key thing is you don't want to take this more than about 3 months at a time. Your body will you'll start to lose it. It loses its benefit at about 3 months. And so this is something you want to cycle on and off. You want to take it for 3 months and then stop for about a month or even just 2 weeks and then cycle back on. What's the medical research? There is a world of research that goes far beyond the muscle. Dr. William Wallace, another very interesting guy to follow. I've heard he's got some conflicts, but I guess we all probably have conflicts, but he talks a lot of good science and has a lot of great infographics on Instagram. But it does more than just things for your muscle. It improves your gut function. It has a lot of research being done in the brain and on the ability to prevent cognitive dysfunction, something our patients definitely suffer. There's a lot of data for its benefits on the brain. And so there's some really great reviews that have been done on this. This is one of the more recent ones. And it shows where the data seems to be strongest, where it may be effective, which is a lot of our patients, but again, a lot of our patients are the other groups as well, and where the data hasn't been as strong. There was some pretty extensive work done in ALS and Parkinson's disease by the NIH that didn't play out, sadly, looking at sort of its neurologic effects as well as its effects in those diseases. But there's some very positive data in a lot of these other areas like acute injury, immobilization, and others. And again, we need to continue to do more research. And then there was luckily, this year, a really great publication looking at adults with chronic disease, exactly who we're talking about, done by Zudin Pujacherry, who's a good friend and an outstanding nutrition researcher from England, looking at 33 trials of 1,000 patients. And what they found was physical function via sit-to-stand was markedly improved. Why we're not using this routinely at Duke and every other hospital around the world is beyond me. Its upper muscle body strength was improved. Hand grip muscle strength was improved. Basically, all the muscle function tests they looked at were improved by taking creatine, and lean muscle mass went up as well. And so the conclusions from this meta-analysis were creatine supplementation improves sit-to-stand muscle function and lean tissue mass in older adults with chronic disease. And again, we continue to need more trials to show this. But I think given the safety of this, I mean, this is really something we should be using commonly. Again, more than 1,000 articles in Pubmed in summary, improves cognitive performance, improves physical function. I have my mom who's got some cognitive impairment taking it, improves strength and lean body mass, and it may have significant organ protection effects in the brain. Now, just briefly on propranolol, anybody that's worked on a burn unit has probably used propranolol, but not many other people have. One of the key things to understand about the hypermetabolism of illness is that burns and sepsis and other critical illness lead to significant hyperadrenergic response by catecholamines. That's why kids remain hypermetabolic, as do adults, for a long period of time. This increases energy expenditure, makes the calories you give not go as far. They get turned into fat and not into muscle. Muscle gets broken down, and patients get more insulin resistant. And this can increase tenfold, this hypermetabolic effect, for up to 2 years post-injury in surgery. It's been shown to increase for months, and this like routine surgery. And so the idea is, can you attenuate this with a beta blocker? And propranolol is particularly attractive because it has beta-3 activities. And the beta-3 receptor is what affects this metabolic effect on muscle and other organs. And so by giving a beta blocker, you can reduce energy expenditure, you can reduce insulin resistance and increase anabolism, and do all the good things that our patients need to recover. Now, where does this data come from and what's the level of strength of this data? It's outstanding. So this is a New England Journal paper that looked at burn children. And what they found was again, they were feeding these burn kids, were very successful feeding the burn units, but they would put fat, their livers would get hugely fatty, and they'd have fatty tissue in their abdomen, and you could feel how big their livers were. They weren't gaining any muscle. And so when they put them on propranolol, they did really intricate and precise measurements of resting energy expenditure and found significant reductions of resting energy expenditure when propranolol was used. More importantly, it's the only thing that has been shown to meaningfully make a burn child anabolic. So they gained muscle mass using very precise techniques when propranolol was used. And you can see in the other group that was very well fed, they were losing muscle despite being very well fed. And so this, again, it's 24 patients, but it's one of the smallest, most convincing New England Journal trials ever, right? This is really potent data. The other interesting thing is, even in septic shock, where you'd think you'd never want to give a beta blocker, there was this really neat study that they did in septic patients who remained tachycardic after resuscitation. So their lactates were normal, their levofed was down, they were getting better. And so they randomized those patients to get esmolol or not, to reduce their heart rates less than about 100, 105, 100. The patients who got that beta blocker had a 40% reduction in septic shock deaths. It's a compelling study that is hard to explain, other than the fact that, again, this hypermetabolic state is not good for patients. And the other key thing is, this wasn't all sepsis patients, right? Not every sepsis patient you resuscitate remains tachycardic. But the data would say, before the study was done, that patients who remain with a heart rate over 105 after markedly effective resuscitation, so they're well resuscitated, they remain tachycardic, their mortality in some studies is 80 to 100%. This is a bad omen if your patients remain tachycardic after resuscitation for their long-term outcomes. And so this beta blocker seems to affect that. So the way you dose this is, it's 5 to 10 milligrams POTID. You titrate a heart rate down to less than 90 to 100, and that's your target. This is easy to do in kids. This is harder to do in elderly folks because it's renally cleared, and renal clearance goes down with age. So again, lower doses in people over 65 is critical because their clearance is reduced. You might give an 18 or 20-year-old who's burned 20 milligrams POTID, where you might give 5 milligrams BID to an elderly person because it takes them longer to clear it. And so it's really important to titrate. Now, to get to probably what you came here to listen to, what about testosterone and what's the data for that? This is the true anabolic agent that I think we've all been talking about. And I think one key thing is, we don't want to give testosterone in the very acute phases, the first 3 days of critical illness. That's when the body needs to, the best of its ability, be catabolic and be supplying amino acids by breaking down muscle to fuel the immune system and to, provide glucose to run away from the tiger, run away from the surgeon, or run away from the bus. So again, this is a really critical time where you don't want to give it, but then after that, the data gets very compelling. And we know the original data was done with oxandrolone, which is a very anabolic specific agent. So again, testosterone agents have two effects. They have the anabolic effect and they have the virilizing effect, the sort of manly features part, the part that that changes sort of our virilization that induces those effects. And there's a different balance of those effects from each different drug. Testosterone's about even, both anabolic and virilizing, whereas oxandrolone is like 15 to 1 or 12 to 1, depending on who you ask, purely anabolic. So that's why it was used by a lot of bodybuilders, but it was developed to be purely anabolic. So this was a randomized controlled trial that looked at length of hospital stay and number of surgeries. People who got oxandrolone, which is now standard of care, although it's been taken off the market in the US, so that's really frustrating, but hopefully we'll still find ways to get it. But this data showed they had significantly reduced length of stays, significantly reduced numbers of surgeries, significantly reduced sort of surgical wound complications. There was all kinds of benefits to this, and that's why it's become standard of care in burn units around the world. When I visited burn units in South Africa and in poor countries in India, they all use this. So this is not something it's a very cheap drug, and it's used around the world. In fact, the NIH did a large trial looking at the effects of oxandrolone on death after burn injury, and there was a marked reduction, about a 4-fold reduction, 3-fold reduction in death from using oxandrolone. So the data for that in this setting is potent. So again, we know that patients who are sarcopenic and cachectic, and especially in illness, have a lot of things that drive that. And some of it's mitochondrial dysfunction and inability to use nutrition substrate. But one of the other things is we know that patients, both as they age and when they're sick, have significant losses of anabolic hormone secretion. Again, the body is not thinking about making muscle when it's sick. The problem is it doesn't think it's going to live, and so it doesn't turn it back on for a long time. And this starts with aging. So male testosterone production drops markedly with age. So the average testosterone level that when you measure one drops precipitously as we age. Now remember, Elijah's 89. He is in the bottom of this. And when these are measured, they vary through the day. So it's very important that when you measure testosterone, the ideal time to measure it is early in the morning. That's why it's really critical that when these levels are sent in the average well person who's not sick, these are sent in the morning, although ideally in sick people, it's nice to take their morning labs. When you add a testosterone level on at Duke or at another hospital, I always try to add it on to the morning labs. And then it's great because it's an add-on test. It's very inexpensive. When you measure the total testosterone, it comes back in about an hour. And when you add it on, it's often added on to morning labs, which is perfect. But you can see how the levels vary in age by day throughout the day. These are the average testosterone levels by age up to age 60. So you can see a normal level in an adult male is somewhere between 500 and 600. Anyone who's seen the testosterone levels of our sick patients at Duke, they're nowhere near this. We'll talk about that. And there's quite a range on this, but these are the levels, and you can see how much the levels, actually the average levels drop by age. So what about when you're sick? What about when you're in ICU? What about for Elijah? So when I check testosterone levels, and the dietitians that know I do this, not infrequently, they are severely deficient within 3 to 5 days after a hospital or ICU admission, especially patients in the ICU. And there's a lot of data for this that we'll talk about, but we see this all the time. We often see levels less than 100. We just had a patient I checked last week when I was in the surgical ICU that was undetectable. That is common as well. You want to be at least over 300. That is the target level, and we'll talk about that. Now, what is the effect of testosterone when it's low on death and outcomes? And there's a lot of data for this, actually. So again, when you look at normal people, these were volunteers, these were normal people, these were at the VA, they did this study in the VA. And if you look at their survival curves over time, men with a normal testosterone level have a much better survival than people who have a low testosterone level. So if you look at the blue versus the green over time, there is a massive effect on survival. So just having a low testosterone is bad for you. Now, there may be other things that are wrong with the people that have a low testosterone in theory, right? So maybe there's other contributing factors. They're sort of how they care for themselves and all these other things, but there's a lot of things that have nothing to do with your diet or how you how active you are that make testosterone low. And so some of these, this is just genetic and unfortunate. And when you have a low testosterone level, even when you're healthy, you're going to die sooner. And I'll show you some reasons specifically why you die sooner that relate to heart disease and stroke in a minute. So a normal T in this study was considered over 250, just so you have a sense of what they were measuring. And then this was mixed and this was low. So this was low at less than 250 to clarify that. And so again, this low testosterone level doubled your risk of dying, adjusting for confounders. And I think that's what's so critical. This is adjusting for the other things that, like disease state, and illness and other things that could confound why you're sick. So just having low testosterone alone predicts a faster death and a shorter length of life. So what about in hospitalized patients? Again, there is an incredible jump in the risk of dying in the hospital, hospitalized patients, if you have a low testosterone level. And you can see this is a really brilliant way to graph the data. Patients who are above 500 do really well. Patients who are below 500 have almost an exponential rise, a really drastic rise in death versus patients who are not. And so again, this is what happens to our patients when they get low. The chances of them dying goes up enormously. And so again, 53% of the patients in this study had a testosterone level less than 200. So this wasn't just a few people. This was half the number of people they studied that had levels that were quite low. And so this is what we're saying. It's very common. And so there's significant increase in mortality in patients with low testosterone. And so what about respiratory failure? Low testosterone levels is common. They looked at patients who had respiratory failure in the ICU or in the hospital. Again, 93% of patients are testosterone deficient. These are like our ICU patients like Elijah are deficient on day one. That's virtually every patient, right? 94% are deficient by day 3. And this significantly correlated with increased length of time on the ventilator and increased length of stay. So if you come in and you get deficient in those first 3 days, your chances of survival and your chances of staying on the ventilator are much worse. So this gives you a sense. This is virtually all of our patients who become deficient, and the lower they are, the worse off they do it. So if we're going to replace testosterone in these patients, and I think I'm going to show you some compelling reasons why, how do you do it? And I think the best advice to do this correctly comes from the American Urologic Association guidelines. And even they say, and these are a really great set of guidelines, if you want to know how to do this better, there's a large percentage of men who need testosterone therapy who fail to receive it because of myths and concerns that people have held for many years that just aren't true. And those are things like you'll get prostate cancer if you take it, you'll have a stroke or a heart attack if you take it, you'll have some other complication, blood clots or something else. We all hear this in the hospital. I hear it at Duke, I hear it everywhere I go. And men hear this from their primary care doctors. But the truth is the current evidence fails to support these concerns. And even since these guidelines were published, the data would say they're completely wrong. That actually, you reduce your risk of cardiovascular events and strokes if you have your testosterone replaced. So again, people that just in general, even if you're a well person that should have testosterone replaced, all kinds of different areas. Diabetes, that's a lot of our patients. People on steroids, people who've had chemotherapy, people who've had radiation, lots of different people who've had fractures. This is a large body of our patients already who should be getting considered a testosterone replacement before they ever see the hospital. So again, the cutoff that is typically used is less than 300, and that's what they recommend. And the diagnosis should be done with 2 measurements. This is for outpatients, honestly, because sometimes they're close, but those should be done in early morning testing because that's when the level's the highest, like we showed you. And so this is how the test is done in the outpatient setting. And this is made when they have a low testosterone in combinations with symptoms and signs, things like loss of strength, fatigue. It could be sexual symptoms. It could be bone density. It could be falls. It could be fractures. Lots of different things contribute to that. But that's key, I think, in the outpatient setting. This is the algorithm that's used, and there's other things that in the outpatient setting are often measured. Again, people who are very polycythemic, who have very high hematocrits, probably should sort of be more thoughtful about using testosterone because it does make your hemoglobin and your anemia improve. So again, for our ICU patients who are often highly anemic, and many of our ICU patients and hospital patients are very anemic, this actually improves their hematocrit quite nicely. And so again, for them, it's a benefit, but for the outpatient, you want to measure hematocrit as well. And your target range is 450 to 600. Most physicians that I have talked with who do this routinely target 500 to 600. You want to check a testosterone level 5 to 6 days after the IM testosterone cypionate, which is very commonly used around the world. It's the drug we often use at Duke. It has a half-life of about 9 days. And so again, then you want to check testosterone levels every 6 to 12 months in the outpatient setting. And this is a really great recommendation that people who have testosterone deficiency, actually, that is a major risk factor for having heart attacks and having cardiovascular disease. So again, it doesn't cause them, or it doesn't cause you to have them. When you're low, you have more of them. So people low testosterone have much more heart attack and cardiovascular disease. And so this really goes against the literature that people were hinting that maybe this caused that. It actually doesn't. Being low causes it. And that there there is no evidence that links testosterone therapy to prostate cancer. And there's a lot of data for this. There's no association. I'm going to show you a New England Journal level trial that shows you there's no association, but all the guidelines say that. So people are often told this, it's not true. And they should be informed there's no definitive evidence linking this to strokes or blood clots. You often will hear this even on the floors at Duke and other hospitals. You'll have pharmacists say, oh, doesn't it cause clots? We can't use it. That is not true. That is not where the evidence is. And that's not what our guidelines even say. So what about this cardiovascular risk problem? We often hear it's going to cause heart attacks, it's going to cause strokes. Again, this is Portuguese, sorry, but the data says actually the opposite is true. It actually reduces your risk of cardiac stroke and heart attacks and other cardiovascular disease. And so this is some of the compelling data that exists. This is a JAMA Internal Medicine study from 2017. They studied 43,000 people, and they had two groups, people who got testosterone repletion, those who didn't. And these were documented deficient patients. These are people who had known testosterone deficiency. This was done actually by the Kaiser Group in California. And they followed them for 3 to 4 years, looking at stroke, heart attack, other cardiovascular events, MI, TIAs, sudden cardiovascular death. And what they found was testosterone replacement therapy significantly reduced cardiovascular events, dramatically reduced, in fact, cardiovascular events. It reduced your risk of a cardiovascular event by 33%, by a third, reduced strokes and other cardiovascular events again by 30-ish%. This is a massive reduction in risk for our patients. And so again, many of our patients have high risk of coronary and stroke disease just by the nature of the other illnesses they have. And so we're doing them a favor when we replete it to help them get out of the hospital as well. So these findings definitely support the use of testosterone replacement therapy in testosterone deficient men. And so what about patients who have known heart disease? What about our patients in the CTICU, patients in the CICU, patients who have coronary artery disease already that have recently had heart attacks? So Intermountain Health did a great study. They looked at 750 patients who had recent severe coronary artery disease and events. And they looked at testosterone either by M or by patch. They followed them for 3 years. Patients not receiving testosterone who had testosterone deficiency were 80% more likely to have another major cardiovascular event. So again, if you have heart disease, you definitely should get this measured and repleted. So again, this is many of our patients, and they're very deficient. And so we're increasing their risks 80% if we don't help them and replete it. So again, so testosterone significantly reduced risk of major adverse events, including stroke, heart attack, and death. Then there was this fascinating study done where they looked at testosterone replacement therapy with a gel versus not, looking at the cardiovascular safety. This was a non-inferiority trial intended to show either risk or safety of testosterone in patients for cardiovascular disease. And this was 5,200 men with existing or high risk of heart disease. Many of these patients already had heart disease, who were treated when they had a low testosterone or not, with a placebo or an intervention. And they were targeted to levels between 350 and 750. Primary endpoint was any other cardiovascular event, heart attack, or stroke. And what they found was there was no difference. In fact, the placebo towards the end tended to have higher rates of heart attack and stroke, but there was no difference in this study of these particular patients. Again, I would advocate that IM is a more effective way to replete, but again, patch is can be very effective for certain patients as well. Not as effective in the hospital because absorption can be quite variable. But nonetheless, no risk at all. And in fact, there was no change in the risk of prostate cancer either. Again, not many patients got it, but again, in this large sample over a long period of time, it did not increase prostate cancer as the other studies have shown. So the conclusions again were that there was, in people with low testosterone and a high risk of cardiovascular disease already having it, there was no risk of adverse cardiac events versus prostate cancer or prostate cancer versus placebo. So why is the difference in data now? Because there was old data that showed that testosterone replacement therapy did increase cardiac risk. It's different. It's very different now. So again, they did a large meta-analysis and they figured out that the patients who had an increased cardiovascular risk were taking oral testosterone therapies. And oral testosterone gets aromatized to a metabolite, DHT. It's in the skin and your liver. And this metabolite, DHT, which is a key intermediate in the testosterone pathway, significantly leads to the risk of cardiac disease, stroke, and all-cause mortality. And the oral has a much higher, obviously, rate of this conversion because of the liver first pass than intramuscular administration. And so again, this really explains why the data is so different now, because we don't use these oral forms anymore, at least we shouldn't. And so again, this IM is the safest route, and this is the route that reduces risk of coronary disease. Also, we do a lot of heart transplants at Duke, and these are patients that often have low testosterone as well. Patients that have a low testosterone actually have adverse effects on their hearts when they receive them, and a higher rate of rejection. And so again, this is something that perhaps we can intervene on and improve by repleting testosterone, because a low T increases the risk of rejection, and so there's a chance we can improve upon that. This has been studied in heart failure. There's a number of studies that show improvements in 6-minute walk distance and other functional outcomes in heart failure when testosterone is given. This is the meta-analysis data. There are not a ton of trials. We need more of them, but the trials have been pretty consistent, showing benefits in exercise capacity in heart failure patients. So how to do this right as we sort of get towards the end here. Again, we want to check total testosterone. It's often an add-on lab. You don't need to check free testosterone in sick patients. Their levels are so low, it's not like you're making a borderline decision much of the time. I mean, when somebody's testosterone comes back 295 or 315, looking at their free testosterone in the outpatient setting is useful. That's not going to be the case in most of your inpatients. Again, most of your patients are going to be massively deficient. So, but I think it's very important to test and to follow your therapy. Testosterone cypionate, we used to say 200 milligrams every 2 weeks, but I have learned more and more data now that 100 milligrams every week, especially in a hospitalized setting where it's easy to give, is really the way to go. You get better evenness because the half-life is 9 days. And so people at the end of that will have drops, and they will feel it even. They'll feel different after the 9 days. And you get a much less even therapeutic window. So you get these peaks and valleys, and your peak is higher and your valley is lower, and you don't want that. You want evenness. In fact, some people would say you should give it twice a week, which I think is a little much, and I've not seen data to support that, but 100 milligrams IM a week is what I do now, and I think there's good reason for that physiologically and pharmacologically. Lower doses in smaller people. This is done in women with doses of 50 milligrams, often 50 to 75 milligrams in women. Your targets are a little lower. You check the total testosterone level, again, with the add-on lab 5 to 6 days after the first dose. You want them 500 to 600 in men. Women, a target of 400 to 500 is a reasonable target. Some people even say 350. But again, in the women who are actually going to do this for in the hospital, we're trying to induce anabolism and help them recover. So we do this in our worst cases. And then, of course, you've got to give enough protein. This is the paper we published. This covers all the forms of available testosterone that are commonly used. There are some longer acting IM forms that are used in other countries and sometimes in this country, but we don't see them too commonly in the hospital setting. But I'm happy to talk to you about those if you would like. But this is a really good reference if you want to learn more. So as we finish, what happened to Elijah? So again, this was a patient who had a cardiac arrest in the operating room. He's 89 years old. He had an open abdomen on the ventilator, but was very passionate about wanting to recover and go and meet his granddaughter. So what did we do? So we started him on a high protein ONS with HMB after he was able to take oral nutrition, 2 grams per kilo of protein, testosterone IM 200 milligrams Q2 weeks. Started him on creatine. We were able to get it. Julie Thacker helped us get it. We repleted his vitamin D. Again, that is essential. It took 100,000 units PO weekly. You can't replete people who are this sick with 50,000 units. You need probably as much as 500,000 units, which is what the JAMA study showed to reduce mortality in the ICU. So 500,000 units even once a week is safe. And actually that gave it 500,000 units once a month in that study, but 100,000 units once or twice for the first week is a good way to get them repleted. It's, again, you have to get vitamin D fixed. And then we had physical therapy do really aggressive work with him. He did walking and chair sit-to stands, exercise bands in the bed. The family brought in his dumbbells that he asked them to bring, and he was using them in the bed. But the question still is, this is an 89-year-old with cancer who's malnourished, who had a cardiac arrest after a major surgery and then had an open abdomen. Can he survive this? Well, the reality is Elijah walked out of the hospital 28 days after his admission, after that cardiac arrest, on his 90th birthday. And that is the truth. I didn't make that up. Walked out of the hospital on his 90th birthday. It was a miracle. This was a picture he actually asked me to take, and his family asked me to share with you. This is him. He's holding his dumbbells in his hand. This is in Duke Hospital. And he went home and lived another 2 years. He met his granddaughter. He got back up on the roof of his church again. He had the life he wanted. And when he did pass away, he passed away with his family around him peacefully, not in some dramatic event in the hospital. So we gave him his life back, despite all the odds, despite everyone saying we would never save him, we should withdraw support. This is possible. This is possible. It was a miracle in some ways, but really it wasn't. It was just the great application, the ideal application of anabolic agents with good nutrition and good rehabilitation. And this is what's possible with that. And so, again, we must train patients for the marathon of their lives. This is not something that they can just do on their own. We have to be there in every facet of their care to do this. And again, behavioral change starts with us. We need to be good examples for our patients and take care of ourselves. But the reality is, if we're going to create survivors of our patients and not victims, we have to be better. And we can be better. Using anabolic agents, good nutrition, and other interventions, we can take patients who look like this, have them walking on their ventilators, which I hope we start doing more of at Duke, because lots of hospitals are doing it. And we can ultimately have patients like this look like this when they leave the hospital, or perhaps even look like this. But ultimately, what we want is patients that go home like this. And Elijah was a great example of that. He got to do all the things he wanted to do. So with that, I will make a plug. If any of you out there want to learn more about clinical nutrition, of course, we have an online fellowship now at Duke. We have 37 physicians and dietitians and pharmacists enrolled in it. So any specialty can enroll in this. We start the courses in January. It's taught by the very top faculty in nutrition that I love to learn from and whose lectures I love to go to the most. That's how I pick the faculty. There's a module every week, and there's a Zoom session where you actually get to interact with your classmates. They come from around the world. Right now, we have 4 continents, 14 countries, from every corner of the world, and all different practices. And so I learn as much from the students as I hope they learn from me and us, because I really get to hear about their practice all over the world and how they do nutrition. And so again, our goal was to improve this lack of nutrition education. We know 75% of medical schools don't teach any nutrition. And so we really want to create an opportunity for physicians and other specialties to learn at the very highest level. And again, the other cool thing we've gotten funding to do is we've started a Duke Online Clinical Nutrition Research Training Program that actually is going to teach specific courses and modules to teach clinical nutrition, population health, QI work, all the key things you need to do great nutrition research. We're going to start that this fall. And in fact, we've gotten funding for a Duke Clinical Nutrition Research Track Fellowship. And right now we have funding to fund 2 fellows that we're going to pay for the statistical analysis, mentoring, and for them to publish papers and present abstracts at major meetings like ASPEN, ESPEN, and SCCM. And so we're working with CAPER to do that. So in the end, right, this is what we're left to do. We just need to do it. I encourage all of you who are on social media to follow me on Instagram and Twitter, and to follow other people as well. It's the best way to keep up the literature. I try to post all the newest literature, nutrition, exercise, and anabolic agent science. And I'm happy to share these slides. I will make sure they're all in English, and any of the papers that you heard me talk about today. And I look forward to your questions and any emails that you might want to send with questions. Thank you.
Thank you, Paul. That was excellent, as usual. I did get a couple questions if you were going to share the slides, so that's great. I'll get away if you want to share it with me. You probably won't be able to share it by email, right? It's normally.
I can make a PDF of it and I'll share it. I'll share it as a PDF. Okay. Is ultimately what I'll do.
Awesome.
And people can get it that way. And I'm happy to share it by email as well, but you can share that with them as well. And that's small enough to email.
Okay, awesome. I didn't see any specific question. There was one comment about curious about the dosing for HMB for chronic illness patient population.